Dialectical behavior therapy, or DBT, is a comprehensive, multimodal treatment approach originally developed for individuals with chronic suicidal ideation and later refined for those diagnosed with borderline personality disorder. At its core, DBT integrates behavioral science, acceptance-based interventions, and dialectical philosophy, grounding its clinical strategy in the interplay between acceptance and change. Developed by psychologist Marcia Linehan in the late 20th century, DBT emerged from her recognition that traditional behavior therapy was often experienced by emotionally vulnerable clients as invalidating and ineffective. When Linehan shifted towards empathy and mindfulness alone, she encountered the opposite problem. Clients felt understood, but they still remained stuck in their behaviors. The therapeutic breakthrough came when she reconciled these two extremes into a dialectical model that simultaneously validates the current experience while guiding them towards positive behavioral change. The theoretical foundation of DBT lies in the biosocial model, which conceptualizes BPD, or borderline personality disorder, as the outcome of an interaction between biological emotional vulnerability and an invalidating environment. Emotion dysregulation is central to this model, encompassing both heightened emotional sensitivity and difficulty in modulating between emotional responses. In an invalidating environment, children do not learn how to label or regulate their emotions effectively, resulting in a lifelong struggle with affective instability, impulsivity, and interpersonal chaos. DBT addresses these challenges by teaching clients to accept their emotional experiences, while also developing skills to manage them in a more effective way. DBT is delivered through 4 interrelated treatment modes: individual therapy, skills training, which is often done in groups, phone coaching, and the therapist consultation teams that ensure fidelity and resilience among their providers. The therapeutic process unfolds across 4 stages, beginning with pre-treatment, where the therapist and client assess their fit and establish treatment goals. Stage 1 focuses on achieving behavioral stability, prioritizing life-threatening behaviors such as suicidality and self-harm, followed by therapy-interfering behaviors and quality-of-life interfering problems. Stage 2 addresses post-traumatic and mood-related symptoms, often termed, quote, quiet desperation. Stage 3 targets residual problems in living, helping clients pursue ordinary happiness, while Stage 4 is oriented towards their deeper goals, such as spiritual integration and the cultivation of a meaningful life. Clinically, DBT employs a dialectical stance throughout, emphasizing that truth is best understood as the synthesis of opposing perspectives. The central dialectic in DBT is that clients must both accept themselves as they are and commit to change. This tension is operationalized in therapeutic strategies that balance acceptance and change. On the acceptance side, DBT uses validation strategies ranging from simply active listening to expressing radical genuineness, where the therapist relates to the client as a whole and equal person. While on the change side, DBT uses behavioral techniques such as chain analysis, which tracks and modifies problematic behavioral patterns, and skills training to equip clients with tools for mindful awareness, emotional regulation, interpersonal effectiveness, and distress tolerance. Each skill module supports a specific therapeutic goal. Mindfulness anchors the therapy by cultivating a non-judgmental awareness of the present moment. This allows clients to engage reality as it is. Interpersonal effectiveness helps clients meet their needs in relationships while also maintaining their own self-respect. Emotion regulation builds strategies to modulate intense affect, and distress tolerance teaches survival skills for enduring acute emotional pain without resorting to harmful behaviors. These modules are typically taught in a year-long curriculum with built-in repetition and application across different life contexts. In addition to these foundational skills, DBT incorporates exposure strategies, both formal and informal, to reduce emotional avoidance. Contingency management, drawn from operant conditioning, is also used to reinforce skillful behavior and reduce maladaptive responses. Cognitive modification strategies, such as contingency clarification and restructuring, challenge rigid and dichotomous thinking by inviting a more nuanced dialectical reasoning into the room. DBT is a principle-driven approach, and that requires the therapist to flexibly respond to the client's moment-to-moment needs using the most appropriate intervention within the dialectical frame. The goal is not merely symptom reduction, but the cultivation of a life worth living. This vision is sustained through a continuous dance between change and acceptance, precision and compassion, structure and spontaneity. DBT ultimately rehumanizes both the therapist and the client by affirming that suffering can be understood, endured, and transformed, not by just choosing between validation or change, but by holding both simultaneously in tension and in movement. Thanks for watching.